sound working? Sound good? Okay, cool. Hey everyone, it's my pleasure to introduce Dr. Harris Sair. He's from Johns Hopkins. He's the director of the Division of Neuroradiology there. He's also a researcher in resting state fMRI and is co-director of the Radiology Artificial Intelligence Laboratory there. So he's going to talk to us today about resting state fMRI principles and applications in brain intelligence.
Thank you very much. Thank you first for the really kind invitation, and then the hospitality has been incredible over here. So thank you. It's an honor for me to be here. So we're going to talk about resting state fMRI. And so we'll talk about kind of background so everybody's familiar with what resting state fMRI is. And then, because actually out of curiosity, mostly residents here now, right? So
all the fellows.
all the fellows, yeah. What about fMRI in general? Maybe a little bit, yeah. Okay. So we'll talk about some applications of this. So I'll start off with task fMRI because I think it's good to know, what we've been doing since 1990s, right? So is that if how task fMRI works, the principle of task fMRI is the assumption that if you have a certain area of the brain that's active, then you get a little bit of a change in really the blood oxygenation and blood flow to that region. So if you move your right arm, then your motor cortex on the opposite side, right, the left motor cortex, is going to get a little bit of vasodilatation, more blood flow, and then more oxygenation in that area. And then you can measure that difference using MRI. So essentially what we do is we show patients, control images, baseline, and then we have them do certain kinds of language tasks. For example, in this case, we can show them letters and say, okay, think of all the words that you can think of beginning with that letter. And then another letter, they'll repeat the same thing. And it goes back to control. This is to try to get rid of all the other stuff that's happening in the brain, like visual activation and attention system stuff. And we do this back and forth because the signal that you get is very, very low. And essentially, you try to figure out where in the brain did the signal on MRI, I don't know if you can see my mouse because it's tiny, point or something, but where in the brain does the signal go up and then down and then up and then down like this during the examination? Because any part of the brain where you saw the signal going up when the language was happening and then down when the language was not happening, theoretically should be related to language, right? So you map that out back onto the brain, and then you get these kinds of images where it tells you, okay, these specific regions of the brain had this modulation when somebody was thinking about language, then the signal went up. So when you look at these sets of images, then these are some of the classic areas where you get language activation like Broca and Wernicke, some dorsolateral prefrontal cortex activation, which I think many people are familiar with. The question really, though, is what's the relationship between anatomy and function, right? Because primarily for neurosurgical applications, you want to take out lesions, but you want to preserve as much of the brain as possible. And I know many of you have heard maybe this thing that we only use, 2% of our brain or something, but that is obviously not true, right? Because the brain is like every other part of the body where if you're not using a part of it, then it's going to liquefy, it's going to disappear. So you are using all of your brain at all times, hopefully. But the question is brain function and the anatomical substrate of whatever function that is it localized or is it distributed? And this is kind of interesting historical perspective here too, because we didn't always think of the brain as having different regions of the brain that have specific function, right? And so Franz Gall, anybody know who that is? Like history buffs or anything like that here? Anybody know who phrenology or what phrenology is? Yeah, so it's like essentially it's a science or pseudoscience of determining human faculty, how good people are doing things, right, cognitively, based on the shape of the skull. So Franz Gall was the one that introduced that. And then now, how many of you believe phrenology? Okay, good. Nobody really believes it anymore. And at that time, too, people were very skeptical. And this is where this guy comes in, Florence, who was actually a student of Broca. And Florence's perspective was that the brain was very distributed, meaning whenever you had to do something, right, think of words or any kind of cognitive function, then the entire brain was working together to accomplish that task. And then so what we did was he was a scientist, so he would did dog studies where he would section the cerebellum little by little. And then his results showed that the more of the cerebellum he took out, the dogs became more ataxic. So there's kind of like this linear relationship between how much of the brain you take out and then the result. Whereas Franz Gall, his idea was that no, different parts of the brain do different things. Localization of brain function, which was actually not a common concept at that time, right? And then this is where he said that, well, based on the shape of the skull, you can tell what's going on underneath in that part of the brain because that part of the brain is doing something specific. Meaning if you have a huge frontal bossing, like they thought that you were a very aggressive person because that's where your brain function is located. So these two, who do you believe? Given what I just showed you, the task fMRI seems to localize brain function, right? And that there were specific areas of the brain where language was noted to be active when they were thinking of words. It turns out we tend to want to view the brain as having local functional regions. Like if you think about the visual system, then it's in the visual cortex, right? So I think a lot of people know that motor cortex, right? The precentral gyrus. Everybody knows that that's the area of the brain that subserves motor function. But what about the rest of the brain? This is a super interesting study that was done like more than 10 years ago at this point now from the NIH, where they did a visual stimulation task, and then they tried to figure out what else was going on in the rest of the brain. And the reason why this worked was because they took few patients or subjects and they scanned over and over and over. Like I think it was like 100 times or something, which is a lot of scanning. But the reason fMRI is a little bit challenging is because the signal is very low. But if you repeat the scan over and over again, then you can stack that signal, right, and get much better signal. So that's what they did. And then so as you expect, the blue is when they showed that checkerboard pattern. And so the occipital lobe has high active signal expected. And then same on the other side, it says bilateral here. And then a little bit of a different signal, but you see the modulation of another part of the occipital cortex here that changes when you have the active task, right? But what about other areas that you may think are not related to vision? So you look at the right thalamus, and then you notice that, well, in the thalamus too, the signal is increasing during a visual task. Okay, maybe they put the region of interest in the lateral geniculate nucleus, which has something to do with vision. But what about the putamen? It looks a little bit noisy, but you see a little bit of a difference in the signal when the visual task was active versus not active, right? And then what about superior temporal cortex? I don't know what that does, other than if it's in the back part, it has to do something with visual motion. But anterior insula, now I really don't know what that has anything to do with vision, but you see like this modulation of the anterior insula as well. So it turns out that when you look at the brain function in detail with good signal, it seems like really the entire brain is working, even when you think a specific area of the brain should be subserving the function. Meaning, if you have a visual, task, then yes, your visual system is active quite a bit, but the rest of the brain is also modulating related to that task. So this kind of brings up to my soapbox philosophy of eloquent cortex, which I think a lot of people have heard about. In the context of like brain imaging and neurosurgery, eloquent cortex is some area of the brain that if you damage, then it would be obvious that the person has a dysfunction, like motor function or language function or visual function, right? And historically, I think surgeons were focused on trying to determine eloquence versus non-eloquence, just because it was easy to tell after you do surgery if the person has any kind of deficit that's eloquent or not. But I think there's a shift in mindset now, and thankfully in the neurosurgical community as well. So this is not 5 years old at this point, but people are starting to view as the whole brain as important, which is good. So every part of the brain is important. Some parts of the brain may be slightly more important than others for certain kinds of things. If you have kids, maybe you have a favorite kid, but all of your kids, you know, you like, hopefully. But that's the same with the brain, is that there's maybe parts of the brain that's more obvious when you start damaging it, right? But every part of the brain is working for something and it's important. And instead of trying to minimize deficits with eloquent cortex, we really need to minimize deficits with every part of the brain. But we previously didn't have information on how to extract that information about what that part of the brain is doing. So for task fMRI, one of the issues is that you're assessing very specific functions, right? You have to design a task like, okay, look at this sentence, read the sentence, think about words, and then essentially the brain activity is kind of focused on that specific task. And then some of the other things is sometimes the patient, especially if they have large brain tumors, they cannot perform the task too well. And you also have to have moderately expensive equipment and train staff, although it seems like you guys have a lot of money because this building is all new and is nice. Hopkins, we don't have any money at all. And so we are super hesitant and reluctant to, like, you know, invest in like things that are expensive. So is there an alternative? And the answer is yes. So this is where resting state fMRI comes in. So for task fMRI, you have the person do something in the scanner, and then some part of the brain gets a little bit more blood flow and oxygenation, and you're measuring that. In resting state fMRI, you're actually measuring the same signal. You're trying to measure blood oxygen level in the brain. And I'll kind of go through right now, just believe me for a second, and I'll show you how it works in the next few slides. In both task fMRI and resting state fMRI, brain activity is related to regional cerebrovascular changes, meaning if some part of the brain is doing something, then that part of the brain should have some kind of vascular changes. The difference is that in task fMRI, you ask them to repeat a task, right? Like move your arms, think about words, et cetera, et cetera. And then you try to figure out, okay, when the signal went up, when they were doing that, that's the area of the brain that we're interested in. In resting state fMRI, they're just laying still in the scanner. And you don't tell them to do anything, but you just are acquiring all of the images the same way you acquire task fMRI, except you don't tell them to do anything. And somehow we can get information about brain function when the patient is not doing anything or the subject is not doing anything. So how does that work? The analogy, before we get to the actual nitty-gritty of how this works, is to me that these fMRI differences are kind of like how the ocean is, meaning in the brain and in the ocean, there are naturally occurring fluctuations that happen constantly, all the waves that are happening. And then task fMRI, what you do is you perturb that. And then let's say you throw a stone in the water, and then you're trying to measure the ripples of what you're doing, right? So it's an intervention task. Resting state fMRI, you're not actually doing anything to change the signal. You're just looking at the signal and then measuring it and then getting information. Essentially, you're measuring information about the inherent waveform of the brain. Okay. So let's say you have a brain, I hope you have. So let's say everyone has a brain, and then you put a region of interest in the right parietal lobe over here. And this is real patient data. So I'm not making it up, even though I think it's easy to make up. Over, like in this case, it was a 6-minute resting state MRI acquisition. So this is the kind of signal that we got, the naturally occurring waves that happen in that part of the brain. So just based on that, now what kind of conclusion can you all make? Right? It just looks random. But next part is the slightly mind-blowing part. So if I put a region of interest in the opposite side of the brain, which doesn't have really direct vascular connections, but this is called the homotopic region of the brain, which is like a mirror image part of the brain. And I extract the signal. And again, I'm not making these waveforms up. This is from real data. Then this is the waveform that came out from there. Okay, so now that looks funny, right? Because when the patient was not doing anything and the waveform looked completely random, for some reason, the left side of the brain and the right side of the brain in the same kind of opposite location have pretty much the exact waveform. So that means that there's some kind of communication going on between those two parts of the brain. Otherwise, this is not something that would happen by chance. Now, just to prove to you, and by the way, you can actually calculate this. Here's the correlation. So in this case, the correlation coefficient was 0.9, or sorry, 0.79. And then if you take another part of the brain, just to show I'm not making stuff up, between the red and the green now, does that show a lot of correlation? Not really. So you can measure this and then say, well, the Pearson correlation coefficient was 0, close to 0. So there's not much communication going on between the region of the brain and the green region of the brain. Again, when the person is in the scanner doing absolutely nothing, they could be sleeping, and that's perfectly fine. Any other region of the brain, you can get these measurements and these numbers, okay? And then so now that you can measure the connections between, or the similarity of activity in different parts of the brain at rest, you can now modify that and create what we call a connectivity matrix, or what we call an adjacency matrix. So you put these numbers together. So between blue and then the red, if you just fill that in, right, the number was 0.79. Between red and the green, it was close to 0, so 0. And then between blue and the orange, it was 0.26. And so the easiest thing to do first is, let's just go along the diagonal, because the red versus red is the same waveform by itself. So it's 1, and then everything along the diagonal is going to be 1, right? Because you're just measuring the same waveform. Now, you can color code this and say, okay, areas where they have high synchrony, let's color it towards the red spectrum. And then areas that are low in synchrony, let's color that in blue. So orange, kind of higher on the end over here. Blue, not much of a correlation. 0.26 is somewhere around here, greenish, and then 0.4 is kind of like the middle, which is yellow. So now this color-coded image shows you in a snapshot, like that 5 regions of the brain and how they're all related to each other. So this is pretty powerful right there already, because now you can tell very, very quickly that red and blue and orange are probably going to be somewhat more related to each other than, for example, green and red and orange, right? My colors, yellow, sorry. So red, blue, and yellow may be a little bit more synchronized overall compared to red and orange and green. And so you can do this with the entire brain. So instead of doing 5 regions of interest, in this case, we took 1,000, which ends up with a pretty small region of interest. And you end up with this beautiful picture. Now, can anybody make sense of this or not really? No, right? Because it just looks like noise. All we did was just calculate the correlations. But what if we kind of shift things around so that ROIs, regions of interest that kind of had similar waveforms, we all kind of move towards the same location. So because, like, let's say red and blue and yellow had similar waveforms, right? So I'm just gonna, instead of having red, blue, green, yellow, orange, I'm gonna move yellow 1 step forward. So red, blue, and yellow are next to each other. That's all I'm doing. So if you reorganize the information a little bit, that's all I'm doing, not doing any kind of extra calculations, then you get this. Now, this is crazy, because now you see some kind of pattern in the brain, right? Across the entire brain. And what happens is that if we take the diagonal here, like that big square over here, or that big square over here, big square over here, and say, hey, you know, let's map out all the regions of interest, because we kind of shifted them on the matrix here, right? But let's say those are regions of interest number 100 and to 300 something. And tell me where in the brain is that big square. Just map it back out into the brain, right? Then you end up with this kind of map, which is not random. So essentially, the squares on the diagonal end up representing different, what we call intrinsic brain networks that all have a similar function that are kind of working together. But again, going back to the principle of the entire brain kind of, you know, working in sync, there's some kind of calculation you can make with the entire brain, but those square areas tend to have much more convergence within themselves. And when you map that out into the brain, then they actually represent systems in the brain. So when you take each of those squares, right, and say, okay, that big square, let's map it out, the smaller square, let's map it out, you end up with these common networks that people have been able to find. There's some more than this, but these are the ones that are more common. And I want to make sure I'm good on time. Yeah. So the default mode network, for example, is in the precuneus retrosplenial cortex parietal lobe, basically in the medial prefrontal cortex and then the lateral parietal lobes. And this system is very, very active when people are daydreaming, kind of mind wandering, not thinking of anything specific in particular, not doing anything that's goal oriented. So this is kind of like a mind wandering type of, hopefully nobody's done daydreaming, that kind of network. And super interestingly, these are also the same locations that are heavily implicated in Alzheimer's type neurodegeneration, meaning you have very high amyloid deposition in all of these areas. And you also have very high dysfunction, in nuclear medicine, in especially like the precuneus and the retrosplenial cortex, right, for Alzheimer's disease. With a region of interest in the hippocampus, you actually end up with a default mode network. So maybe it has something to do with memory as well, but that's a super interesting network. And then there's another one called the salience network, which involves the anterior insula and the anterior cingulate. And this one also I find fascinating because it's like, even though the next one's called the executive control network, this one is actually the control system of your intrinsic and extrinsic brain function. So what this does is synthesizes the information within yourself and in the external world and tries to figure out which stimulus you need to pay attention to. Okay, and so sometimes the stimulus is internal. Again, like if you're thinking of something super hard, right, then you're not really paying attention on even when you're driving, actually, this, right, that you go into a zone and you go into a trance, and then you have this like thought function that's going on, that salience is kind of picking that as your focus. And then you're not really focused on the driving, and then suddenly you realize, oh, I got home. Same thing. And then if there's some kind of external stimulus that is critical, like there's a car passing by, you might get into an accident, the salience network is saying, hey, you need to switch, pay attention to that thing from outside. And this is a network that, people talk about like ADD, ADHD, right? Where there might be issues with attention, but it turns out it may not be. I'm not like the expert on this thing, but just my own philosophy is that ADD, ADHD may not be really a function of attention, because my understanding is that if the individual is interested in something, they can razor sharp focus, like video games, TV, that kind of stuff. But the issue is that the switching is the problem, right? So you're at school, you're daydreaming, and then teachers trying to have you pay attention to the board, but all the stimulus internally is much more important for the salience network. So that's kind of why I feel like this is a really interesting network. The executive control network, parietal and frontal lobes bilaterally, this is kind of decision-making kind of network. The attention network I mentioned, oftentimes it's there's a dorsal and ventral system, but essentially paying attention to, visual, spatial stuff, surroundings, et cetera, et cetera. And then motor network, which people know about, and the sensory one you can lump into there, visual one in the occipital lobe, auditory network in the temporal lobe, and then the language network, which typically is lateralized in the left frontal and temporal lobes. So if you wanted to play around with this a little bit, then you can go to this website and then put in like a region of interest anywhere you want. And I put in the coordinates of region of interest if people want to kind of generate your own networks. And then if you put in those coordinates and then do, I think here, then the network would show up like this. So if you put a region of interest in the parietal lobe, then, the default mode network would show up. Now, this is partly related to how the processing is done, but we talked about like the brain as being one organized unit, right? And there is this concept of anti-correlations, meaning some networks are active and correlated within themselves, like the orange areas here, yellow-orange, which is the default mode network. And then there are some brain networks that are working the opposite of that network, depending, again, how you process the data. So in this case, like the attention and motor system here is working opposite to the default mode network, meaning when the default mode network is very active, then the attention and motor systems are not very active. And the reason why this could be important is because, well, not the reason why it could be. The reason why this is important is because it still tells you that there's some kind of communication going on, right? Because if there wasn't any kind of communication, then the relationship would be zero, meaning regardless of what the default mode network is doing, the motor and attention system would do something independently. But the fact that it is doing things in opposite when you look at the waveform that means that there's some kind of inhibitory effect, at least when you do this kind of processing, that when the default mode network is active, then the other networks are suppressed and vice versa. So again, going back to the principle of the whole brain really kind of working in sync. And how do you analyze? So some of the techniques that we have, so we can put a region of interest in the brain, which we did earlier, right? And one of the techniques is, okay, you put the ROI in a certain area of the brain and say, what other areas of the brain have this kind of waveform? Just tell me all the areas of the brain that have this kind of waveform, right? And then you might end up with something like this, which is like a super low resolution study. But if I put a seed in the motor cortex, then you end up with a central motor system. And this is very crude without processing that. Even without processing, the information is actually there. Or you could do what we did earlier, which is, okay, pick two regions and then say, what's the correlation between them? And you can get some numbers. You can pick multiple different brain regions, which we did earlier, but we took them individually, right? But you can also do things like graph theory, which summarizes relationships between different regions of interest and then calculate metrics of this system itself to end up with like a single numeric value. For example, the degree is how many each of those ROIs is connected to. So the yellow is connected to 4 other ROIs, the green is connected to 2, right? And I don't remember what the other ones were, but basically, if you just take an average of the whole system, then you can say, okay, the average degree is like 3 or 4 or whatever. And then efficiency is like how quickly you can get from, for example, the blue to the red. Can you go directly? No, right? Because there's no link, but you have to go through yellow or orange. And then so that would decrease your efficiency. So there's a lot of other parameters that you can calculate from that. The other method is to do what we call independent component analysis. And what it is you just dump the data into an algorithm and say, hey, this is all the waveforms that are available in my data. Just can you separate them out into as many different waveforms as possible? Which is kind of like the inverse of saying, can you lump all the waveforms that look similar together just naturally, right? But you have to tell it how many. So you say, okay, I want you to separate all these waveforms into like 3 different buckets. So it'll tell you, okay, bucket number 1, the waveform looks like this. Bucket number 2, waveform looks like that. Bucket number 3, waveform looks like that. And you can map those different buckets out in the brain. And some of them will actually end up representing noise because this is not directly targeting neural signals. But within all of the data that's available, including noise and brain signal, you'll see some of these maps that represent, like this is noise because it's in the ventricle. It's just CSF noise. But this is actually the anterior part of the default mode network. So you have to go through these maps and then find out which one may represent real brain signal. The pros and cons are that seed is hypothesis driven because you know where you're putting the ROIs, right? But the problem is in patients who have like brain tumors and things like that, it can be hard to figure out where to put the seed, right? If somebody, if you're trying to do like language mapping, and then somebody has a large lesion that is involving the inferior frontal gyrus on the left side, and there's so much mass effect, then you don't really know where you can put the seed. Whereas ICA, the benefit is that you don't really tell it anything. You're just getting the data out, and then you just have to find which map represents the language system afterwards. The issue with this one is that you have to pre-specify how many outputs that you want. And then sometimes it's hard to figure out because I think I'll talk about it later, that if you ask for too many, then you're going to get too many results. If you ask for too few, then the data is going to get mixed up. So we'll talk about that in a second. One of the problems with fMRI, resting state fMRI, is that nobody can seem to agree on what to call these networks. So I have my own way of kind of describing them. And there was a group with the Organization of Human Brain Mapping that decided, because nobody can, some networks everybody agrees on, but some of the other ones, if you look in the literature, they're called by like 3 to 5 different names. So in order to unify the nomenclature so that people can actually compare, results, they tried to do more of an anatomic designation of labeling of networks. But to me, that's not very helpful, because if I tell the neurosurgeon, hey, it's the mid-singular insular network, like, okay, so what, right? But if I tell them it's the salience network, so now they know that, oh, salience, it's the one that is like this, the ones that's looking for salience switching. Or attention network, if I call it the dorsal frontoparietal network, they'll be like, okay. But then if I call it the attention network, they know, okay, you know what, if I cut through this area, then maybe I'll disrupt attention. So I prefer more of the functional names. But this is the problem, is that they did a study asking a bunch of people who do resting state fMRI what to call different brain networks. And then they show them in different ways. So on the left are some examples of networks that everybody tended to agree on. So that's like pretty much motor, visual, default mode network. It's easy to identify. And then the one on the right turns out has super low concordance. So 20%, 15%, et cetera, because I kind of suspect half of this is noise. And then so that's why nobody knew how to label them. But there's some things that don't look like noise. Like that one is in the amygdala, right? But maybe people are not familiar with like neuroanatomy as much. I don't really know, but there was not really a good concordance. So that's why they were trying to figure out this taxonomy. So now I mentioned, patients are subjects, either one, subjects being healthy control sometimes for research, are just in the scanner, and then we're getting these signals, when they're at rest, right? So, but how long do you have to scan? We started off with 6 minutes because back in the day, way back when, there was some literature showing that 6 minutes was sufficient and reproducible to get good resting state quality data. And then I started doing 6 minutes for our surgical candidates, right, for preoperative mapping. And then at one point, I was like, I thought I need to quit my job because I was not getting very good results. Like some patients, I got beautiful results. It's like, I don't golf, but whoever golfs over here, I'm hearing it's the same thing, is that even though you may suck most of the time, if you hit one good shot, then it keeps coming back to you. That was resting state for me, is that occasionally I would get this beautiful map and share with a neurosurgeon and get excited saying, yeah, we got to do more of these. And the next 3, I see absolutely nothing. And then, so I scratched my head with this, and then on a whim, I decided to just kind of increase it to 10 minutes. And then completely opposite now is that now I'm getting beautiful results. So for our scenario, the way we do our acquisitions, it seems like 6 minutes was okay for some patients, but not good for most patients. And 10 minutes has been good for most patients. Some other people recommend doing 15 minutes, but that's kind of long for one scan. So they split it up 7 minutes and 7 minutes and combine those two. Some people say 30 minutes is necessary to make sure you have stable network depictions. And we'll talk about this in a little bit. And other people said, you got to do 90 minutes, Jeff Anderson, which nobody's going to stay in the scanner for 90 minutes. I mean, that put your chairs down like you do that. So, you got to be practical. So we did 6 minutes before, now we do 10 minutes. And WashU, they do 15 minutes, and they actually were one of the first in the country to integrate into clinical practice, and they've done a marvelous job with doing this. So now they're doing fMRI on all of their kind of brain patients with brain tumors where they have to get surgery, and they have an automated system that's using a little bit of, not deep learning, but multilayer perceptron neural networks to kind of label the different networks automatically, and it's worked out really well for them. At Hopkins, we end up doing more ICA-derived analyses just because of, again, my bias towards the pros and cons of seed versus ICA. And to me, this is actually quicker to do. I don't have a very good automated system of doing it yet, and that's why I needed to minimize the time I'm spending on doing the analyses. And as I mentioned before, you have to kind of specify how many target components you have to have. And then if you have too many, for example, networks have different subcomponents within the networks themselves, right? And so the best way to think about this is that it's kind of like all of this is hierarchical, meaning, like I mentioned earlier, and I keep repeating, the whole brain is working as an integrated unit. So at the very large or the biggest viewpoint, when you take a step back, you can say that the brain is one integrated network. Now, when you separate that out, the second division becomes, okay, now you have an internal network and an external network. The internal network being like the default mode network and the salience network, although salience is kind of mixed. And then the external network being like attention network and motor network and all that kind of stuff, right? And when you break that down even further, then you get into, again, motor versus attention versus blah, blah, blah. And then you can break down the networks themselves, again, into like the DMN can be split into the back part or the front part. The executive control network can be split into left and right, et cetera, et cetera. So really the choice of where you want to draw the line of what a network is kind of up to the individual. If you want to be granular, then you can do that and describe the networks in more detail. Or if you want to kind of, if you're a lumper, then you can describe the networks in kind of more broad strokes. So if you end up with, the goal is really to get like, the standard depiction of these networks in one map each. So what happens is that if, for example, you find that the salience and executive control are connected in one map, or the motor and the visual are showing up in one map, then the solution is actually easy, is that you end up forcing increase the number of components. So if you say, initially, I wanted 60 different outputs from ICA, then you might say, okay, instead of 60 now, give me 100, right? And then so now things that were together may be able to be split. Vice versa, if you feel like things are too granular, and now the attention system is broken into ventral, dorsal, and frontal eye field, and then it's kind of confusing as to how to label them, then what you can do is to decrease the number of target components and say instead of 60, show me 30. And then oftentimes they converge together, and then you can depict the networks as you want to. With the caveat that at an individual level, this is not as clean as it, as I make it out to be, in that sometimes the networks are connected in very bizarre ways, like the default mode network might be connected with one part of the language network and not the entire network and that kind of stuff. So you want to know like the anatomy, and I'll just kind of skip over this one, the anatomy, and then kind of what kind of networks could belong together to try to label them correctly. So again, this is data from the WashU folks, but they did some early studies on using resting state fMRI in patients with brain tumors, and then found that compared to task fMRI, which one this is, but basically they were getting good overlap of results of resting state motor mapping with task fMRI. And then we did our own studies looking at different parts of the motor system. And here with task fMRI and then rest in red and then resting state in green, and the overlap is in yellow, right? So in this particular instance, if we got good results like this, then we don't have to do a task fMRI anymore. So the patient can get imaging anytime, even overnight, because they don't have to do anything, and we don't have to have that specialized equipment to do task fMRI. You can even get things like the supplementary motor area if you kind of do some seed-based analysis. And so these are the kinds of maps that I am providing to the neurosurgeons now for preoperative mapping. Now it sounds kind of messy, but it's also pretty, so it's nice. So each of the colors represent different networks. The blue represents the language network. The green represents the executive control network. The orange, yellow is the motor network. Pink is the default mode network. And then yellow is the attention network. Now, I am giving all this information. The critical ones, the eloquent ones that they were paying attention to before are motor and language, right? And all the other ones, the funny thing is, we don't really know what to do with at this point, because we know they're there, but we don't really know what is the effect of actually resecting that area, because previously they didn't care about it, right? Previously, they were only looking at the orange and the blue here and cutting anything that got into the way of the lesion and then trying to take out the lesion. But now, if I don't know where the lesion is over here, where the lesion is, but let's say there's a lesion here. Now there's, I mean, where's the access point if you want to try to avoid damaging, any of these networks, which again, we don't know what happens if you take out like the left parietal part of the attention system, but I guarantee you something is happening to the patient because that part of the brain is doing something. It's just that we were not able to measure it properly before. So one of the goals is that we need to do some really, really detailed neuropsychological testing to try to figure out what the deficits are that are induced by taking out these networks that previously we weren't really paying attention to. So like here's a brain tumor, and then all these networks around there, and then using this as guidance, then they're able to kind of find a trajectory to get to the lesion without disrupting the more obvious networks. And then again, all parts of the brain being important. I'm not saying that this part of the brain is not important, but I'm saying that we don't really know what that part of the brain is doing, but I do know that this is default mode network, right? And then this, I remember what the blue is, language system, and some other visual systems over there, that if we can try to avoid it, let's try to avoid it. And so this is a really great example of a case that we did early on and gave the neurosurgeons a lot of confidence in this tool, because I think that's critical. The first couple cases, if it works well, then they'll keep asking you, right? The first couple cases, if the outcome is bad, then they're going to say, no, I don't want to risk it because obviously patient care is most important. So here was a lesion that was in the anterior cingulate. And then the neurosurgeon said, hey, can you map out the supplementary motor area? Now that, it wasn't any of the core networks. Sorry, not the supplementary motor area, the supplementary motor area. So the SME is hard enough to get with resting state fMRI, but now he wanted to do one that was even harder to do, which is supplement pre-SMA. But thankfully, the powers that be were kind enough for this particular case. And then the supplementary motor area showed up like the strongest I've ever seen in any patient. And then so I was able to generate these maps and then provide a neurosurgeon. So this is your supplementary motor area, pre-supplementary motor area. And I was able to provide a trajectory that's not really shown well over here, but in real time kind of evaluation with the neurosurgeon, a trajectory that would avoid all of the visible networks to get to the lesion safely. And the patient did extremely well. And then the surgeon was like super happy about this. One of the problems is that if you only have resting state, right, there's a lot of networks that show up, all those different colors. Now, if they're interested in language, how do you figure out which one is language? And it turns out it's not really easy because you think, oh, it should be in the inferior frontal gyrus on the left and posterior temporal gyrus, right? Superior temporal gyrus on posteriorly. But it turns out that one part of the attention system has a lot of overlap with the language system. So when I did the study and gave our seasoned faculty who did like 20 years of doing fMRI analysis, including some of resting state, and then some other raters that had less experience, gave them resting state fMRI data. And I told them, like, find which one is a language network. And for this, we had gold standard of the task fMRI, so I knew where the language area should be. It turns out even the person with the highest experience of decades of fMRI research and interpretation clinically had less than 3/4 accuracy of identifying that network, which is a problem. And then the one that they made the most mistake with was the attention network, because again, here, the language network is actually in the red, and then the green orange over here and here. And the attention one is in blue. And you can see that if you ignore this one, these are very close to each other, that they can maybe mistake the attention system from the language system. And then the other thing that you can do is, I think we talked about this a little bit yesterday, right? Yesterday, yeah. Is that you can take task fMRI, but during the task fMRI, remember I said that the brain is kind of like an ocean, and the task fMRI is throwing a rock into the ocean and evaluating the ripples. But the ocean waves are still happening. So why don't we, can we not use resting state fMRI analysis techniques to evaluate those background waves in addition to the ripples that you induced with the rocks, right? So that's what we did here. This is a language task fMRI, and they did absolutely no motor mapping. But if you do ICA analysis on language task fMRI, then you can generate the other networks, including the motor network, which basically the overlap here is in white, and it localizes beautifully to the motor system. And then, I guess more evidence type stuff, but resting state networks correlate very well with intraoperative mapping. And then some of these networks also have a correlation with, this is kind of what I was getting at earlier, is that, okay, what exactly happens if you disrupt some of these networks, right? This is not that study, but in this particular study, they looked at what we call a verbal memory network, which I think is a default mode network, honestly, but they looked at that network and then saw that if you disrupt that, then you have, or the level of connectivity in that network had some kind of correlation with postoperative deficits. So here's basically what that is that, which part of the brain had a higher risk of post-op deficits, and essentially it's the connection within the default mode network. Now, one of the issues is that even though I'm talking about like networks as a whole, each person's brain is unique, right? So we did some studies to try to figure out how different are the different networks across everybody, because we're not robots and we're not identical. And this initially started off as a reproducibility study on individuals. And then the resident, who's now at Stanford, he really like took this project out far and then got some really interesting results. So what we ended up doing was we had 2 scans per each patient or subject. So let's say everybody here had 2 scans, time point 1, and several days later, maybe a week later, another scan, right? Now, I don't know how many people are here, but let's say there's 30 people. So now I have 60 scans. What we do is we dump those 60 scans into an algorithm and try to ask the algorithm to pair up just using the functional connectivity matrix data, which 2 belong together. So I'm not asking, these are the first ones, find the ones from the second ones that match the best. What I'm saying is these are 60 studies, find the ones that pair together, right? And that's conceptually very, very different. And the algorithm was actually able to do this with 97% accuracy, which means 2 things. Number one, that reproducibility is high per individual, but also that each individual's pattern is unique enough because it doesn't get mixed in with other people's, right? And so when you map the part of the brain out that determined how unique individuals are, like which part of the brain had the most effect on pairing the scans together, then you end up with this map, which was really nice to see because it kind of makes sense that the blue areas had not much to do in terms of pairing scans together. And those blue areas represent like motor systems, visual system, like more primitive systems that are really not that different across individuals. Whereas the orange, yellow, red, those are the areas that had the largest effect on individual pairing the scans together. And so those are all the association areas, which again, kind of makes sense that the association areas are higher cognitive function, right? And can determine more individual features. So we talked about tumor resection, and that's kind of what we're using it at Hopkins. But I think something that is equally exciting in the future is targeting like these brain circuits for interventions, right? So let's say you have a certain kind of patient population, and the theory is that, okay, you identify a target at an individual level, and you do some network mapping, and you can individualize the network target based on the brain functional connectivity. And I'll show you an example in a second. And then you essentially do some kind of intervention. Now, for neurosurgeons, it's cutting out the brain, but you can do non-invasive modulation, TMS, TDCS. You can do DBS, again, maybe in the realm of neurosurgery. You can do HIFU. You can do MR-guided focused ultrasound, et cetera, right? So you can use intrinsic brain connectivity patterns to try to do interventions. And the guys that I think this was Brigham have done a lot of work on this. This is the Brigham folks. So they've noticed that in patients with depression, for example, there's different patterns of connectivity based on seed-based analysis. And depending on the type of connectivity that was evident at baseline, their response to treatment actually was different. So now you can try to predict. I'm just going to go through a little bit quicker just because of time, and then that you can try to classify which patients might do better based on different patterns of connectivity and depression. And in this particular example is that the connectivity of the dorsolateral prefrontal cortex really had a high effect on how well the patient would do following transcranial magnetic stimulation. Or in patients with anxiety, there's certain areas of the brain based on connectivity that show up that have a high effect on treatment for anxiety, even medication. So they're kind of expanding this to beyond depression, anxiety, addiction, mania, pain, volition. So this is a very, very exciting area that I think would be useful in the next years. So since this technique has been around for like 10 at this point, the technique was actually developed in 1990 something, but clinically, I think people have been doing it more in the last decade or and a half. But for some reason, we haven't really implemented this, very widely yet, right? So this was a really nice study that was done by Aaron O'Connor at University of Maryland about asking folks, why is it that you're not doing resting state? Because it's easy to acquire, which is the first thing that everybody agreed upon. But then the next couple of things that everybody felt was that they don't really know how to analyze the data, right? And then there's some kind of interpretation problems and how to interpret the data. And then so This is kind of where the research comes in, and then this, which anybody know what that is? It's the Forbidden City, which even though it's forbidden, you can go in. But in the Forbidden City, this is where the royalty used to live, right? And then there's this thing called in front of the building of the Ministry of Weights and Measures. And the reason why I think this is so cool was that basically the vendors in China had to go to the Forbidden City, I think every year or something, and then make sure that their weights that they were using to sell people rice and things like that were correct. Basically, the government would say, hey, this 10-kilogram thing that you're using, stone, is actually 14 kilograms or whatever it is. And then they would make sure that that was accurate. So standardization, super important. And that's one of the problems that you have with resting state fMRI, because there's task fMRI, everybody kind of converges upon doing GLM analysis, which is very standard to do now. There's some other ways of analyzing, but 99% of people use that analysis. Resting state fMRI, there's so many different ways. There's seat-based ICA, like I mentioned, right? And then there's actually techniques beyond that that I didn't even go into. So we need to first standardize it. So we tried to do some of that as a group here. And so this is an article that came out relatively recently. If you wanted to do resting state fMRI for language motor mapping for patients with brain tumors, then some parameters that we could suggest. But for resting state fMRI to be clinically useful, the clinicians need to pair up with researchers to come up with the standardization and techniques to make it easier for people to analyze the data and interpret the data. And even beyond that, now, with the interventions that I mentioned before, we have neurosurgery in the mix, because now we can help them hopefully get better outcome for patients, which we have to investigate. But now neurology and psychiatry, with all the interventions that we could potentially do with resting state fMRI targeted interventions, right? So, wow, I talk a lot. So we didn't talk about subject level variability and individuality. We talked about just a little bit, and then functional connectivity, dynamic connectivity, and AI. So I'll go to this part a little bit quicker. Individuality. Well, before that, so I mentioned hierarchical representation of these brain networks, right? So we're trying to do some AI stuff to try to label these networks. But the problem with AI is that when you do classification, it only tells you one thing. Is it default mode network? Is it attention network? Is it motor network? But I'm interested in an AI algorithm being able to tell me to the depth that it can tell me what the network is. Meaning the equivalent is like, let's say that you present an AI algorithm with a picture of an animal, and then it knows that it's a vertebrate, it knows it's a four-legged animal, but beyond that, it doesn't know what it is. Then it'll just say, hey, it's a four-legged animal, right? But if I show a picture, for example, like a poodle, right? And then the AI algorithm can go as deep as it can until it doesn't know what it is anymore. So if it might say that, hey, this is a poodle, and maybe there's like subvariants of poodles that I don't really know about, but that's the kind of stuff I'm trying to do with AI here, is to trying to do essentially hierarchical learning of resting state networks. And it's actually working out not really, really well, but given the challenges of doing this, it's working out way better than I thought. So essentially you train an algorithm and come up with numbers, a latent representation during the training process of what the imaging correlates with some random number. And essentially what happened was we found that there's certain numbers that are associated with networks. Like the first number represents the largest network, which is DMN and 12. Then the second number represents, the sub-network of that, 33 for the inferior parietal lobule, and then 49 for the retrosplenial cortex. And then as you keep going on in the numbers, it represents more and more granular aspects of the network. So we don't have to go through that. And then the dynamic connectivity. So I mentioned that, the length of the study that we do, 6 minutes, 10 minutes is kind of variable, right? And in some patients, it's working out well. It's because these brain networks are not always constantly active. They're engaging, they're kind of dissipating, engaging, dissipating. So when you look at just the motor system, which is all these squiggly lines in the back, if I take the average of the connectivity, it's not that it's highly connected all the time, right? There's peaks and troughs. So there are time points where you have high connectivity, and there's time points where you have not as high connectivity, even within the motor system. And when you map that out of, let's say, like 5 different areas of the motor system, then it turns out that the time point where it was very highly connected, which is number one, was only about 18% of the time during the acquisition. And every other time, it was doing something else. It was not really totally fully connected within each other. So I think that's one of the reasons why sometimes we have difficulty getting, and this is just kind of like a visual representation of kind of like the dynamic changes of 5-second window all the way up to 80-second windows, right? Of the dynamic changes that happen in connectivity. And for some of these, you can see the squares coming in and out, right? That's the engagement of the networks and then dissipation, engagement, dissipation. And so we got to try to figure out a way to try to, like language network, for example, doesn't show up very well all the time. And my suspicion is because the engagement is not as frequent in all patients as the motor network, for example, which shows up beautifully all the time. So some places we tried doing this as well, and then they ended up doing a better job, so we stopped. Is that you can actually put the person in the scanner and generate the networks in real time to see how they're coming and going and coming and going. All right. Somehow I finished in time. So yeah, so we went through a lot actually. So, you know, starting from brief task fMRI, but then majority talking about resting state fMRI, that I think everybody now understands that we can measure functional connectivity. So connections between different parts of the brain, even when the person is not doing anything. And again, they can be sleeping. And these consistent set of networks can be found in the brain. And these resting state networks are potentially useful for targeting later on for neurosurgical interventions or psychiatric interventions. So super exciting area. Really appreciate again everybody coming and then listening. Questions?
So, did you try to do like a control group that would silence the brain as much as possible? Maybe you could silence the brain in resting state and then add some specific tasks and do like a parameter of comparison of those groups?
Well, I guess maybe my lack of understanding here, like how would the silencing work? Because
Maybe someone who meditates.
meditates, yeah. So
Someone who is sleeping or is sleeping under certain types of drugs that you know it will shut up certain parts of the brain.
Yeah.
You can silence certain parts of the brain and make a comparison. Try to separate what the areas are.
Yes, so
instead of doing action, removing action.
Removing action, yes. So they've done some of that with anesthesia. So if you give different types of anesthesia, then different networks tend to suppress, but most of it is actually a default mode network, and all the other networks tend to remain. So the default mode network is the one that is susceptible to kind of anesthetics most of the time. Yeah, other than that, there wasn't much that they could do with suppression of brain function, because it involves kind of,
And sleeping, did you try sleeping?
Yeah, we do it on sleeping people and then we get the same networks.
Oh, okay.
Yeah.
Actually, two questions. Fantastic talk. And in terms of DSM fingerprinting based on resting state, like from the individuality tests on same subjects, but when say a subject is in a manic or bipolar state, they fail the fingerprint.
Yes.
Right? So like that, it's a fascinating area.
Great question. And then I didn't put that in. I usually have that in my slides too, but that's a whole topic in and of itself. So basically, I feel like resting state fMRI connectivity has three different levels that we need to address. One is universal, kind of what we consider typical connectivity that everybody should have if they're considered to be healthy. And then there's the, oh wow, I'm blanking on the name. There's a second level, the trait. The trait, which is your individual level of connectivity, which could be a little bit different than the universal pattern of connectivity, right? But still is considered in most cases like typical for you. And then there's the state, which can change day to day. So this happens is that when you do resting state fMRI, your state can absolutely change the connectivity parameters. Now, it turns out, it seems like the trait and the universal patterns are stronger than the state, which is why you can do this mapping of individuals. But the state is a very, very important question that we need to address. in resting state fMRI. Yeah.
That's wonderful. And then that kind of leads to my follow-up question, which is in terms of biomarkers of disease. So we're all looking for ways to track biomarkers of disease. Resting state and particularly ICA analysis is a great way potentially to look at, as somebody's ICA anti-correlation network sliding down the neurodegenerative toward.
Yes.
And have you looked at that in terms of like anti-correlation networks accumulating?
Yeah, we haven't looked at any like serial data. The problem, but I think actually that may be a solution to the problem I just kind of described, which is that even though the default mode network, initially everybody was super hyped up about it because all these papers came out saying correlation with amyloid deposition and then AD areas of atrophy, and then even patients with MCI, if you looked at the connectivity, some of them said you could try to predict who might convert to AD. But none of them panned out at the individual level. And I think it's because at the individual level, there's so much variability in the level, like my default mode network may be non-existent, but it's still like, I guess considered normal maybe. But somebody else's at the default mode network may be like super strong. It's the same with amyloid in general, right? Is that there's a huge range of deposition even in healthy individuals. Now, the serial evaluation of resting state is very, very interesting. And I think that's a great area to go into to see how these networks change over time. Yeah, it's not something that I've done, but completely agree that that would be very beneficial. Yeah.
A great talk. Thank you. I think I'm not really a MRI expert, so maybe this is a dumb question, but oftentimes what we see in a paper is like a group of bipolar, the healthy control.
Yeah.
Group of anxiety disorder with a healthy control. And it's really the group comparison, and there's some area of like a data dump into something and it pop up something and this is a statistical map. How valid those paper is if you're showing that an individual network is so variable, but you're combining all the people with specific disorder or condition to be in one bucket, as if there's a signature of anxiety, depression. And I just always find that those papers to be very questionable.
Yeah.
Should I be more, believing in that data or?
Yeah, I think the way I see those papers is that I think there's valuable information in there. Again, talking about the universal pattern of connectivity that may be disrupted across groups. But practically speaking, yes. Is it useful to do individual level analysis? And the answer is no, right? Because again, there's so much variability. But there are papers that do these analyses at the individual level and do the treatment, and then they find good outcome based on individual level of connectivity and not group level connectivity. Yeah.
So the gold standard is a task-based MRI instead of resting state, for example, some sort of anxiety disorder, bipolar, like a very subtle thing, not a visual or more. That's like a more robust signal you can get, but it's a very subtle signal we're talking about. And then there are very lot of noises. We try to extract using kind of statistical, I call manipulation, but it's statistical. And then they find something, and this is the area. And I'm like, where's the golden truth? Like a truth in there. It's just observation or association. But I'm really reviewing making a decision for connectivity study.
Yes, no, I agree. I think the problem is there's not a very good gold standard, because even comparing resting state to task, the issue is that when you do a task study, and even if you do like a language task study, right? They're not really the same as the language network in resting state. Like the way I feel is that the resting state really represents the building blocks of the network. And then when you do a task, it's picking the different building blocks to activate. Because like when you do task fMRI, pretty much most of the time, you'll get activation in the contralateral cerebellum of your non-dominant. Well, if your left cerebral hemisphere is dominant, you'll get right-sided cerebellar activation. And that's something we see all the time in our pre-surgical mapping patients. So somehow that is being recruited during the task language task, right? But in resting state fMRI, that never shows up. And then like the dorsolateral prefrontal cortex, even the motor motor, like the ventral motor system shows up in task very frequently. So the task is not, it's supposed to be isolated, but it's not really as isolated as I think we want it to be. So it's a mixture of different things. And then the resting state is like, there should be some overlap, but it's not really equivalent is the problem. And then even cortical mapping, because people try to do cortical mapping to kind of prove that these networks are real. And we like to think about cortical mapping as a good gold standard. When we talk to neurosurgeons, you know, they can actually be non-specific as well, because if you stimulate a part of the brain, then you might have a little bit of a distant effect as well. So you're not really sure if that area of the stimulus was actually the area of concern or whether it was the other area that's remote. So there's a little bit of like a distance as well. So we don't really have good gold standard. I was talking to Tyler about this, but the one thing that I'm really looking forward to is Rag Iron, who's well, I'm looking forward to seeing him too, but I'm looking forward to his research where he does something crazy where he's doing focused ultrasound and then he's encapsulating ketamine in microbubbles or something, and then injecting ketamine and then doing ultrasound, so that essentially only in the area where you stimulate with focused ultrasound, the ketamine disperses. And then so you lose function in that area of the brain. Super brilliant. And then that goes back to your question.
In a human or?
Not yet. Yeah, not yet. Yeah. But it's amazing because now you can do exactly what you were saying, which is to do vision studies. Yeah. Yeah.
Oh, that's,
That's going to be like a decade from now, I think, at least.
yeah.
Yeah.
Oh, wow. Thank you so much.
Sorry, you had a question.
Yeah, but I think it time is over, but thank you so much for great lecture.
Thank you.
One thing I just wanted to ask is comparison between the task phase versus resting state. Very interesting, right? But one of the benefit of task based is that you can actually measure performance of the task.
Yes.
You can bring that information back to the parametric mapping, which is going to actually shape those, results much better.
Absolutely.
But then I thought about it after listening to your lecture. Can you actually standardize or measure consistency of restingness? Because some of those session to session variation, if you think about it, if you're self in the scanner, lots of noise, anxiety, pictures, tech, maybe talking, all of those things. So somehow you have to standardize physiological condition for resting state.
Yeah, that's super good point. And then so there's two facets to this. One is that some people's argument is that even without standardizing the environment, we're still able to get good results. So maybe they don't need to focus too much on it. But there are some people, and I agree with you that it'd be nice to have some kind of standardization. They would do something like show a patient the exact same video across everybody, right? But it's not like they'll a task where they have to do something during the video. They just have to watch. And then it turns out that may affect the networks to a certain extent. Interestingly, I think maybe the Brigham guys tried to do this like 5 years ago, and I haven't heard much since then. So maybe it didn't work as well as they thought it would be. But yeah, I think there were some people that were trying to do that, maybe by standardizing that environment so that resting state is a little bit more consistent. Yeah.
Well, excuse me, has to be a very bland video, isn't it? Because if you bring emotion, if you're showing a video and you do not know how the person who's watching the video
Going to
react to it, even if the person does not want to react.
Yeah.
So maybe you can think about the opposite. Just knock them down by benzodiazepine.
Yeah, that's true. Have everybody sleeping, right?
Yeah.
That's true. Yes. Yeah. You guys got to go back to work.